So today's webinar is the second and final in our series featuring our CanFASD trainees. And so this year, CanFASD launched and piloted an exciting new program for students and early career researchers and professionals across Canada working in the field of FASD. Beginning in January of this year, 8 trainees were invited to take part in our pilot program. Nominated by our CanFASD research leads and associates, the trainees represent a pan-Canadian group of interested students and research support staff from a wide range of disciplines and levels of training. The goals of this program are to build research capacity in the field of FASD, foster mentorship, networking, and collaboration among the trainees and leading Canadian researchers, and to encourage the next generation of up-and-coming FASD researchers. As part of this program, our trainees have the opportunity to profile their work to the CanFASD Research Network through things like blog updates, newsletter updates, and public presentations, including today's webinar. And so given that our trainees are a diverse group of researchers, you're going to hear about a variety of projects using different approaches and methodologies, and all in various stages of completion. And so welcome back to our attendees from part 1, and thank you again for joining for our second panel today. Today, you're going to hear 4 presentations from our trainees on wide-ranging topics, including epigenetic biomarkers of FASD, level 1 FASD prevention, suicidality and FASD, and a framework for housing individuals with FASD. And so our first presenter today is Shea Mulvihill. Shea is from Winnipeg, Manitoba, and is a research assistant for Dr. Anna Hanlon-Dearman at the Manitoba FSD Center and Dr. Jeff Hicks at the University of Manitoba. Shea just finished her 4th year of an undergraduate degree at the University of Manitoba and is completing a Bachelor of Science in Biology, graduating next year. After her undergrad, Shea is hoping to pursue a career in medicine and has a particular interest in pediatrics. Shea has thoroughly enjoyed her time learning and working with everybody. Shea's presentation today is titled Epigenetic Biomarkers and FASD Diagnosis. Over the summer, Shea will be working with Dr. Anna Hanlon-Dearman and Dr. Jeff Hicks on the Translating to the Community T2C FASD Code Validation Project. The project has been examining the link between social factors and prenatal alcohol exposure, as well as establishing biomarkers for FASD that can be used clinically. The project is aiming to provide clinical validation of the FASD code. Epigenetic signatures are a useful diagnostic tool, and this clinical validation will assist in early intervention and diagnosis of FASD. And so with that, we will hear from Shea.
Hi, everybody. Hope this all looks good so far. So as Kelly said, my name is Shea. I'm really excited to be here today. I'm excited to present to you about my project. So first and foremost, here in Winnipeg, I am located on Treaty 1 territory, and the University of Manitoba is on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dean peoples. Now, just a little bit more background on myself. I got into the research at Manitoba FSD Center just back in September of 2021. So this is all very new and exciting for me, and I'm really happy to be meeting everyone. I was working primarily on the National Data Form project, as well as a little bit of adult and preschool research with my supervisor. I then joined the CanFASD program and was then the recipient of the Children's Hospital Research Institute of Manitoba summer studentship. And that is what led me to my summer project. So I am working with the Translating to the Community project, which is an ongoing study with many collaborations and partnerships throughout Manitoba, focusing a lot on translation and community-based research. So this project began in 2016 under the investigation of 3 doctors here in Manitoba, the 2 research leads, Dr. Brenda Elias and Dr. Jeff Hicks, and the pediatric lead, Dr. Anna Hanlon-Dearman. Now, a big focus of the Translating to the Community project is partnership with clinics and communities throughout Manitoba, with a big emphasis on Indigenous communities and their contribution to the project. So out of the FASD clinic in Manitoba, there's also collaboration with the U of M and the University of BC, with a lot of collaboration with the Cree Nation Tribal Health Center and Swampy Cree Tribal Council communities. Now, the research committee is made up of the investigators as well as elders and community leaders throughout Manitoba. They're the ones that are making all the diagnostic decisions and decisions throughout the research, with a really equal partnership with everyone involved. Now, the project is a large collaborative research study, and it's examining the link between social factors and prenatal alcohol exposure and establishing a biomarker for prenatal alcohol exposure and FASD, with the hopes of being used clinically. Now, this has been going on for a few years, and it's one of the largest cohorts for FASD research in the world. There's over 1,000 children involved with over 3,000 control groups. And this is really helpful in determining differences in genetics and matching all of our analysis. With this being one of the largest cohorts, it's really exciting to see the statistical power behind it. And we're hoping it is suitable to use the FASD biomarker in clinics. Now, the overarching goal of the project is to validate the code, and this will help facilitate early intervention and better prevention strategies in communities throughout Manitoba and then hopefully throughout the country. Now, just to get some of that jargon out of the way, what is epigenetics and what are biomarkers? So epigenetics is the changing in genes due to exposures in your environment, as well as behavioral differences and genetic-based differences. So as you're developing and throughout your life, your genes can change due to these exposures, and it'll add on different things to your DNA, mostly DNA methylation, and this will cause changes in your genes and then the phenotype that is shown. This is then seen as biomarkers, which we can analyze in lab to notice these genetic changes and compare them to a normal human genome to determine what the differences are and how this might be affecting you personally. Now, behind all these epigenetics are the social factors that are causing them. And one of the parts of the T2C project was determining risk factors for FASD and what might be causing an increased prevalence in certain areas and what makes more people susceptible to developing high-risk outcomes of FASD. Now, first and foremost, prenatal alcohol exposure will really change the prenatal environment, and the developing child will then have differences in their genes due to this change. As well, biological factors such as maternal age and nutritional deficiencies will impact the developing child as well. Then for social factors in the developing background and family history, such as lower income and lower education, will have a play in on those genetic changes, which will definitely be important to look at to determine risk factors for FASD, particularly here in Manitoba, where 70% of the people coming in for assessment are from Indigenous communities. This is a really important aspect of the study to determine what social factors should be looked at and how we can improve supports in those communities. So here's just a quick visual of everything I was kind of saying. So our genomes, our genetics are impacted by the environment, and that is where we get our epigenome. And that is what's all inside all of our DNA, and everyone's a little bit different because of these environmental factors. And then this is because of those risk factors that we previously mentioned. And this is how we can see the biomarkers and compare them to a normal human genome or other genomes in general to see the differences. This combined with the length and amount of exposure to alcohol will change the outcome of FASD and the phenotype that is exposed in different people. And that is why this is a spectrum disorder, and we see differences there as not everyone is the same and everyone's genetics are slightly different. And that's what this project is trying to see, how those differences impact the outcomes of FASD. So that was just all the background info on the T2C project. It's all very exciting. And then I'm going to be working over the summer with this project on my own little project, and I'm going to explain that to you now. So first and foremost, I really have to work on recruitment, especially with COVID. There's been a really big delay on getting consents, but here at the Manitoba Fsd Center, we have had people consenting to contact for over 10 years. So I do have quite the list to get through there. And I'm hoping to get around 100 participants over the summer. And these I'm going to focus into two cohorts, one being children who were diagnosed at the clinic with FASD and another being a twin cohort. So part of T2C has a twin study, which is going to be looking at really compact genetics, as twins obviously are in the same environment prenatally. And this makes it really interesting because the slight changes in genetics, especially in fraternal twins, will then be very interesting because you can tell the differences, how the genetics impact the effects of prenatal alcohol exposure. Once I get consents for the T2C project, I will need to get samples for my genetic analysis. So I'll be doing this through the most non-invasive way, which is buccal swabs and a saliva sample. So if you look at the little photo at the bottom there, a buccal swab, you're just swabbing the inside of the cheek. It's very easy for children and participants to do, super non-invasive, pretty convenient. So once I get those samples, I will send them over to the T2C biobank where they'll be stored and completely de-identified for full anonymity and privacy of all the participants involved. Now, the biobank is actually super interesting. It's a very large part of the Translating to the Community project. It's located at the University of Manitoba, and it's a fully dedicated and secure facility for these samples. And part of the aspect of this is that since the cohorts and the samples were getting so many, they're going to be held for a long time and potentially used for future studies. And this is going to be really helpful down the road if there's more research that is wanting to be done. And this is all overseen by the FASD Research Committee, and all final say is from the elders and Indigenous leaders in Manitoba. And they're the ones that decide who gets access to the samples and how they're allowed to be used, with guidance from the investigators. And this is the part I'm really excited about. So genetic analysis is what I will be doing after I get those biological samples. And if they meet quality control standards, I can look at methylation and genetic variation of these DNA samples from all these children diagnosed with FASD. And I can then map these to a control human genome to notice different methylations and different genetic variants. So if you look to the figure on the right, you'll see that the control and the FASD samples are quite different in color. And at the top one, you'll see that the control has low methylation. So those genes are often turned on, because methylation turns off genes often. And then in FASD samples, there are a lot of methylation happening there. So we'll see deficits in those areas of the genome. And then this can be used to determine how this impacts the outcomes for FASD and how we can notice that there's prenatal alcohol exposure in the genome. And just to show this in a kind of wrapped up way, so we have the epigenetic and genetic analysis being done, and then that combined will be able to get this FASD code, which they have found, but there's not enough validity yet to determine if it can be used in clinic. So then once there's enough validity and enough proof of this code, we can hope to use it in clinic for early identification of children prenatally exposed to alcohol and determine their risk for developing FASD. And the final part of my project will be doing a survey to get more information on the social history and life histories of the participants and children. So this survey was coined by Dr. Elias, and I'll be using it to ask all the participants and their families or caregivers background questions about their livelihood and just anything social economic like that. It's very similar to the data form questions that you'll see on that, where there's prenatal questions as well as risk factors depending on nutrition and medical history, as well as the FASD domains like cognitive behavior, etc. Now, this is really helpful as it can address the complexities of FASD from the social perspective, as we know this clearly has an impact on the prevalence of FASD and the severity, and this will help us know more about those risk factors. It can also be linked to medical record abstracts, which is not part of my project, but it's a very powerful tool to learn more about medical history as well with the life history. So that's my project summed up, and I'm really hoping to get some good results by the end of the summer. But then here are the overall implications of both my project and the overall T2C project. So first and foremost, hoping to support communities better and equitably. So while we're shedding light on these risk factors that contribute to FASD, we're hoping to be able to prioritize community supports and programs to combat them. So especially if we're noticing lower income areas being affected or lower education, we can then institute supports that will better help those communities. And especially just access to clinics. And in Northern Manitoba, they do have access, but we're hoping to help support them a little bit better. And this is where that partnership with a lot of the clinics and communities throughout Manitoba comes in, as we want to really translate this information and provide more education for FASD throughout the province. Then with the biomarker, with more information, we are hoping to validate the probe for use in clinics. So as long as we get more cohorts and we prove that this is a reproducible biomarker and we can see it over and over again, we might be able to use it in clinic to help identify at-risk children. And this would be super powerful, a really good tool for early identification. So here at the Manitoba Fsd Center, we're based out of Specialized Services for Children and Youth, which is a clinic based in Winnipeg, and it's a really popular clinic for all these children to come in for multidisciplinary assessments. But what we are seeing is a lot of older children coming in middle school or high school when they're finally getting noticed for behavioral issues or academic issues, when in reality, we might be able to identify FASD earlier with the help of this marker, where the marker is not diagnosing them, but at least it's helping show, oh wait, maybe we should go and do an FASD assessment. And with that, we could anticipate early diagnosis of FASD, which is always critical in providing proper supports and really helpful management of FASD in communities and in families. With early diagnosis, you can have better targeted prevention right away, and you lower the risk of an incorrect diagnosis, which of course will help promote understanding amongst families and communities to support people impacted by FASD. And this will hopefully improve their outcomes throughout their life with better support systems throughout the communities. So just to summarize everything I went over, I've been Shea. Hi, nice to meet all of you. And I'm a part of the Translating to the Community project here in Manitoba. We are hoping to validate the FASD epigenetic code to use as an early diagnostic tool to help identify children with prenatal alcohol exposure at an earlier age to help with early diagnosis and instituting better supports in the community and families throughout Manitoba. So thank you very much. I would like to acknowledge just Dr. Hicks and Dr. Hanlon-Dearman, my supervisors, for getting me involved in this project. I'm very excited to see where it goes.
I'd like to introduce our second presenter today, Celisse Bibr. Celisse is a PhD student in Laurentian University's Rural and Northern Health Program in Sudbury, Ontario. After completing an MA studying the knowledge of FASD among medical students, Celisse moved on to study awareness and prevention campaigns on the topic. She is currently under the supervision of Dr. Shelley Watson and Dr. Kelly Harding, myself, so Celisse is my doctoral student, aiding in the development of a new campaign tailored to the city of Greater Sudbury. Celisse's presentation today is titled, "Because if you were a parent and your child had FASD and you walked by this, what is your response? Laurentian University Student Perspectives on FASD Prevention Campaigns." Sudbury is in need of a level 1 prevention campaign targeting alcohol use during pregnancy. However, current campaigns have been criticized for their negative and stigmatizing nature. This project is the first step in the development of a new campaign, beginning with going back to the community. Perspectives of the Laurentian University undergraduate students were gathered on 10 different FASD campaign images. Data analysis is ongoing, but preliminary results and recommendations will be discussed in this presentation today. So with that, Celisse, I'll turn things over to you.
Okay, so before I begin, I just want to acknowledge that Laurentian University is under the Robinson-Huron Treaty, but I am currently presenting in Hamilton, which is covered by the Dish with One Spoon Wampum Covenant and the Between the Lakes Purchase. So like Kelly said, my presentation is entitled, "Because if you were a parent and your child had FASD and you walk by this, what is your response?" And before I continue, I just want to acknowledge that some of the images involve shock value and some graphic imagery, so please be warned about that. So when it comes to seeking knowledge around pregnancy, if you're pregnant and looking information, the types of things you see and the types of people you talk to, generally you might start with a simple Google search. You might see information like this: alcohol use during pregnancy. This is from the CDC website. Language such as "there's no known safe amount of alcohol used during pregnancy," et cetera, et cetera. But if you continue to look in different avenues and different search terms, you might see things like "light drinking during pregnancy may not harm babies, study suggests," "drinking red wine in moderation while pregnant," and "why I drank while I was pregnant. More educated 30-something women, myself included, are drinking in moderation during pregnancy. Why do we do it?" In addition, you might talk to family and friends, and since the mechanisms through which alcohol causes deficits are numerous, complex, and variably activated, and 50% of pregnancies in North America are unintended, and pregnancies usually discovered around the 6th week in gestation, that leads to a lot of alcohol. The alcohol can be consumed unintended while pregnant. And so that may result in advice such as, "your sister drank with her son and he's fine, don't worry about it." So we have this power of the anecdote, where many women report knowing others who drank during their pregnancies and produced healthy children. There's also a cultural norm of alcohol use. If you say going out for a drink, the expectation of alcohol is already there. So there's this encouragement or even pressure to drink alcohol by close family and friends. And there's also the fact that not being able to participate in drinking alcohol leads to exclusion and feelings of isolation, intended or not. So what that means is that women are receiving mixed messages and experiencing varying pressures in regards to alcohol use during pregnancy. And it's possible that these issues could be combated by a campaign to provide advice and education. When it comes to Sudbury specifically, the reported rates of alcohol use are around 1.8% versus national estimates put it at around 10% in Canada. And so you can see a big discrepancy there. We also know that the prevalence rates of alcohol use during pregnancy tend to be higher in rural areas, and that specific regions of Northern Ontario have identified FASD as a growing concern. So the implication of these numbers is that alcohol use during pregnancy is being underreported. When you look at current prevention campaigns, you might see something like this, you might see something like this, or you might see something like this, and they're really based on shock, fear, and guilt. And while these kinds of tactics have been found to be effective for our other health concerns, such as smoking cessation, in the case of FASD, it has these possible side effects, such as increased stigma around alcohol use during pregnancy, increased stress on pregnant women, fear of disclosure of alcohol use during pregnancy, and decreased access to services because of this decreased disclosure of alcohol use. So all of these three things combined, the confusion surrounding the alcohol use during pregnancy and FASD, the stigma preventing people disclosing and therefore getting the supports that they need, and underreporting of alcohol use during pregnancy, which is linked back to that stigma, means that Sudbury could benefit from a tailored prevention campaign to educate about alcohol use during pregnancy without increasing stigma. So that's really the ultimate goal of this study. And it's going to be a series of studies. So this is just step one of that whole big project. So step one is to go back to the Sudbury community and gain their perspectives on existing campaigns. But the Sudbury community is very diverse. So one of those groups we are hoping to target are individuals of childbearing age, which are represented by undergraduate university students. And some of the other populations would include community members, such as pregnant and new parents, as well as their partners. So the study I'm talking to you about today is about the Laurentian University students, the individuals of childbearing age, and it is ongoing. So my research question for the study was, what are the thoughts, opinions, and perspectives of individuals of childbearing age in Sudbury and its districts on existing level 1 prevention campaigns to reduce alcohol use during pregnancy? So level 1 prevention, you might know a little bit about it because it is from CanFASD, but it's this multi-level model discussing prevention of FASD. And so level 1 involves public awareness and health promotion initiatives. Level 2 involves discussion of alcohol use with women of childbearing age. Level 3 involves support for pregnant individuals with alcohol issues. And level 4 involves postpartum support for new mothers. So this study is really centered around level 1 prevention. When it comes to an overview of my methods, we recruited Laurentian University students completing their undergraduate degrees across all degrees and all genders, but we received 6 males and 23 females across 13 different programs of study. 7 participants were Francophone and 2 were Métis. Our data collection involved focus groups with these participants. So they were given a demographic questionnaire that wasn't linked to their individual data, but was just a general survey to find out what populations we might have missed or what populations we did manage to get. And these focus groups were semi-structured. And since the pandemic happened during this study, 3 of them were in person and 4 were online through Zoom. And then data analysis was conducted through reflexive thematic analysis. So if I'll walk you through what the focus groups looked like a little bit. We had 10 different images we handed out. And so I'd hand you these images and I'd say something like, do you think these are effective campaigns in raising awareness around FASD? Why or why not? What is your first reaction to these images? And what do you like about the campaign and what don't you like about it? So these images, I would show you them one by one. So I would hand you this image, we talk about it, hand you the next one, we talk about it, the next one, the next one, the next one. And then I'd hand you back all 5 of those images. And then after we discuss all of them, now that you'd seen them all together, I'd hand you the rest of the 10 so that you could see them all together. So there were 2 alternating rotations of the first 5 images. So that was the first rotation and this was the second. And they were alternated between focus groups, which let us preserve the comprehensive discussion we got on the 1-by-1 image, but preserved our participants' time because all 10 images talking about them 1-by-1 took a very long time. So in discussing my results, one of the things we talked about when we were moving forward with this study is what makes an effective campaign? How am I going to define what will make our campaign effective in the future? And this was actually something that came up as a result through our participants. Participants defined effectiveness in very particular ways. So one of those definitions was clarity. As Melanie put it, this image is the most effective. It does really just get the point across. You can look at it and you just really understand what it is trying to say. So for example, if you're walking by quickly and you see a poster, is this FASD or is this body positivity? Is that FASD or is it? Both of these things were things that participants brought up during the study. Participants also defined effectiveness as attention grabbing and retaining. Do you look at the poster and do you continue reading it, especially the small text at the bottom? So as Ileana put it, I find the image the most effective for the same reasons, really. Just the picture and the color really gets your attention. So this bright red color, does the color catch your eye and would you keep reading? And lastly, they discussed it as different from what is liked. For example, Brooke said, it would help me remember because I don't like it so much. I literally have this image in my head, even though I don't like it at all. So participants would acknowledge that they thought campaigns would be very effective, even though they didn't like it, didn't like what it was doing. And so when we discussed which images they liked the most, we had to separate likability from effectiveness. So 2 different images were seen as rated first in likability and rated first in effectiveness. Now, all of these things were dependent on context. Participants discussed if you had time to read it, if it was in a magazine, if it was on your phone, or if you were just walking by it and it was amongst various different posters. That's completely different. And the perception of the image is genuine. If the expression on someone's face or the nature of the campaign was not seen as genuine, any other effective aspects like good messaging, good language, that sort of thing were. The other result involved the discussion of supportive campaigns versus shaming campaigns. So campaigns that used guilt, blame, and shock value were perceived as more effective, but generally less well-liked. So as Stephen put it, the concern of the advertisement should be preventing it from happening again, not the reaction of somebody who did it. If the child is living with FASD, they're obviously guilty. So participants discussed how shame, blame, and shock value worked to catch the eye and keep the attention. They discussed how consequences and harsh realities could work as deterrents to drink again. But there was some discussion of the double-edged sword of using these types of shaming campaigns. As Peter put it, for me, it was the tone that it set that made it seem effective. Even though I didn't necessarily like how the image was being portrayed, that very dark theme put a very serious tone to it instead of a comical setting, which has the most potential to bring change. That dark has more power for me. And that language power was used a lot during these more shaming, more shock value type campaigns. People used language like strength, power, powerful, that sort of thing. On the other hand, supportive educational campaigns were generally more liked, but perceived as less effective. As Chris put it, I don't think the purpose of any educational advertisement is judge. I think it should be to educate. They discussed how ads could function as conversation starters, particularly with healthcare practitioners. If the ad was hanging up in a health clinic, it kind of opens the door for that sort of discussion, which might be difficult to open without it. They appreciated ads that called on support from others and took the onus off the mother. They particularly liked ads that targeted those around them or targeted the partner, that sort of thing. They appreciated those people being brought into this discussion. They also emphasized resources and information, links to follow, find out more websites, QR codes, that type of thing, that those were all very positively. As Ella put it, I just don't feel like a poster would really stop me from drinking because I feel like the underlying issue would be much greater than that. I would think that the posters need to be supported by something else. So those are my main results so far. There's a lot to go through. But the aims of this study are to explore and summarize my participant perspectives, organize their insights and their advice in order to develop recommendations for future campaign creation. But importantly, we want to take these recommendations back to the literature and compare what put it in the context of what we know about FASD, especially in regards to stigma and FASD. Because as you can see, there is a lot of thoughts around stigma that might not be in line with current recommendations. And we also hope to contribute to a new campaign tailored to Sudbury and move forward in campaign creation by providing recommendations that come from the perspective of those in Sudbury, but contribute to normalizing support as opposed to shame. Thank you very much for listening.
Thank you so much, Celisse. So interesting and so exciting to see some of your preliminary findings. Okay, our third presenter today is Kirsten Morrisson. Kirsten is also located in Sudbury, Ontario, where she completed her BA in sports psychology and her MA in interdisciplinary health at Laurentian University. Kirsten has worked on a variety of projects and a number of different research jobs in different fields before settling into her position as a research assistant with CanFASD. She hopes to continue to bridge her interests together through her work both inside and outside of the organization. And Kirsten's presentation today is titled Understanding Mental Health and FASD. Suicidality is a major concern for individuals with FASD. To better understand the contextual factors related to suicidality and mental health, a focus group was conducted with a group of individuals with FASD. And so Kirsten's presentation today will share the key findings from this focus group and recommendations for supporting the mental health of individuals with FASD. And so I will pass things over to Kirsten.
Thank you for that introduction, Kelly. So as Kelly mentioned, the topic I'm going to be presenting on today is understanding mental health and FASD. And with that comes the topic of suicidality. So I just want to give a little bit of a warning for some sensitive content that may be in the slides, just as we go through this presentation. So I just want to begin by acknowledging that I'm in the Robinson-Huron Treaty Territory, and the land on which I gather is the traditional territory of the Epigenetic Anishinaabe. Give a bit of a background, the definition of suicidality is a spectrum of thoughts and behaviors, including suicidal ideation, suicide-related communication, suicide attempts, and death by suicide. Suicidality is quite a significant concern for individuals with FASD. It's actually found that the prevalence rates in this population is greater than that of the general population. However, there is limited research on this topic, and so it's important to better understand the factors that can affect mental health and thus suicidality to better create more effective solutions. So this research that I am presenting on today is actually part of a larger project on suicidality and FASD, and there were multiple studies within this project. One of those being a scope and review that was done to compile all the literature on suicidality and FASD. Another one was a secondary data analysis of the National FASD database, otherwise known as the data forum. And here we found that 25.9% of the population studied actually reported suicidality, which is much more than that of the general population. There's also a caregiver survey, and there were interviews and focus groups done with 3 groups. So those were caregivers, professionals, and individuals living with FASD. And so the research I'm presenting on today is specific to the interview done with individuals living with FASD. As I said, it was a focus group done with 4 individuals with lived experience, and this focus group was conducted by 2 of the researchers on the full project research team. Questions focused on factors affecting mental health in general, because suicidality is quite a touchy and triggering subject. We decided to focus more broadly on mental health. And participants were young adults, and they spoke about both current and past experiences. The data was analyzing used thematic analysis, so that included developing codes and themes to describe the data. And I used a combination of inductive and deductive analysis. So questions were focused around risk and protective factors affecting mental health. And so I was able to use deductive analysis through that, but we also wanted to allow any themes that might develop from the participants themselves that we weren't exactly expecting. So I used inductive analysis that way. For the results, I developed 2 themes. So the first theme was support, and this had 2 sub-themes, which were everyday support and communication/awareness. The second theme was impact of lived experience, and this had 3 sub-themes, which were emotional aspect of living with FASD, historical experiences, and knowledge of mental health. First theme, support. This one really highlights the protective factors for mental health, but it also highlighted the importance of language use and the significance of using FASD-informed solutions. So here I'm just going to present sub-themes as well as some quotations to support those themes that I found. This research is still kind of in the writing phase, and there's quite a lot that I can go over, so I'm just going to give some key findings here. So for everyday support, this really encompassed ways that we, as well as the individuals, can do things on a day-to-day or regular basis that can facilitate positive mental health. So one of these things is finding a positive outlet. As this quote explains, so we need those sense of positivity and have those opportunities to succeed or excel, whether that's music, art, sports, drama, whatever it is. Having those at a younger age, I think just would have helped, just for myself personally, those suicidal thoughts and things like that, that I would eventually have. I may not have had if I had a sense of self-worth at a younger age. So just finding those things that they're really interested in, that we can support them in and can facilitate that positive mental health. Another thing is the acknowledgement of good behavior, as this quote suggests, because I was talking about how people would always say when I was late or when I didn't have my homework done. But if people took the time to acknowledge when I was on time, or I did finish the project, or I did put the dishes away. So moving away from kind of those negative, oh, what can't they do? You're moving towards more strengths of what can they do and acknowledging those strengths to help just create some more self-confidence. The second sub-theme is communication and awareness. And this really focuses on social connection and just being aware of things like language. The first one talks about kind of community connection. Quote, having people come to the conferences and then, realize, wait, there's other people who have FASD. Oh, you guys get this. And now I have people that I can, walk away from that conference with their phone number or their email, and I have that connection. So being able to have these instances where individuals can find those people where they're not really feeling like they're alone and they're feeling validated in their experiences. But then also realizing that language that we use can sometimes be a little detrimental. So, quote, I think there's a lot of power in language. As soon as you see the letters FASD, the thing that pops into my mind is everything I'm not going to be able to do. So similar to the last sub-theme is kind of going towards those strengths of what can they do. FASD does not mean you can't do everything. Sometimes it just means you need to do things differently, and they need to realize that. So the second theme is impact of lived experience. So the first one highlighted protective factors, and this one more so highlights the risk factors related to mental health. And the last one, because it was related to protective factors, I feel like a lot of people can easily relate to them. So we all kind of seek that validation, the positive reinforcement, finding those positive experiences. While this theme more so is specific to the complexities of living with FASD. The first sub-theme is the emotional aspect of living with FASD. And as it suggests, this kind of talks about those specific challenges that can occur with living with FASD. One of these things is dealing with some mental health challenges. I don't know what comes first, anxiety or perseveration. Perseveration comes first, and then the anxiety comes from the perseveration of whatever you're perseverating on. Another thing is having your kind of regular experiences magnified. Quote, as a teenager, you're weird and different, but we all experience that as teenagers. But when that's been your whole life, it's magnified even more. And so then those things that you're weird, you're different, even our own experiences aren't of the normal. So I think that we can all kind of relate to having those phases where, you know, we don't really feel like we fit in. But for individuals with FASD, this is something they experience every day, and it's not quite a phase for them. Next subtheme is historical experiences. So this one speaks to things like trauma and maybe negative foster care home experiences that they've had in the past that really affect their mental health today. Quote, those kind of things stick with you, and the triggers that you have in the future, they come back to you in the past like a surprise attack that you never expected. Even if like I'm living like the really good life right now, but there are some times like maybe when my boss has the same tone that reminds me of my foster dad. Even though my boss is the nicest guy in the world, sometimes tones really scare me. So again, going back to maybe those triggers, things happen in the past that's still going to affect them in the current day and affect their mental health. Another thing that can is their environment, both past and present, as well as expectations. Quote, I would say it's my environment, surroundings, and expectations. It wasn't fair that I had to do this work or understand these things or whatever when I was 14, because developmentally I was 8. So why are you putting these expectations on me when I'm not able to meet them? So yes, I wasn't able to meet them due to the development of my brain with FASD at that point, but it didn't mean I couldn't do those things later on in life. Last subtheme is knowledge of mental health. And this one I feel like came out more so in the inductive analysis phase. So one of the things was not exactly knowing the root cause of mental health challenges. So I think, you know, learn at the same speed as everybody else and understand things and have a normal life, maybe I wouldn't feel this sense of low self-esteem. So this kind of came from not quite knowing if it was FASD that was causing the mental health challenges, or if they would still have these challenges if they didn't have the FASD diagnosis. And another thing was just basic knowledge of what mental health was. Quote, so I think being able to properly face and I guess cope with mental health is difficult because of the fact we may not fully understand what it is, right? So this one really speaks to, okay, are the feelings, the emotions I'm having, are these normal? Is it because I have FASD? Is this something that I should be seeking support or talking about? And so sometimes it's really difficult to know those signs and to know when or how to seek support. For a little bit of discussion, themes that were presented, they do support the previous research on both relational and environmental factors, but they also provide some new risk and protective factors that haven't been seen in the research yet. It also provides firsthand experience on what works and what doesn't work. So the individuals, they know themselves the best, right? So they know the things that help them, such as the positive reinforcement, the validation, the social connection, but they also know the things that may be causing some challenges in their current lives. So such as the trauma, such as the foster care, they know these things. From this study, we can come up with a few broad general recommendations to better support individuals with FASD in their mental health. One of that is better professional support that is FASD informed. That was a really important thing, that even though there may be professional support out there, it's not always FASD informed, and it needs to be. Another is strength-based approaches. So we know that there are challenges, but there's so many strengths, and we need to lean onto those strengths in order to facilitate positive mental health change. And then last thing is to change how we use our language. So not even just in research and in policy, but we need to change our language and how we speak when interacting with individuals with FASD. To summarize, mental health and FASD is a complex topic with many intersecting factors. The risk and protective factors that were presented today are in line with previous research. And most importantly, individuals give significant insight into the relationship between FASD and mental health, and we need their voices in order to better inform effective solutions. So that concludes my presentation. I want to thank everyone for joining today and listening to me and my peers.
Thank you so much, Kirsten. Such a great presentation on such a sensitive and timely topic. And so I appreciate you sharing all of the voices from your participants in your study. So with that, I will move to our fourth and final presenter today, Vannesa Joly. Vanessa is a second-year student in the School of Clinical Child Psychology PhD program at the University of Alberta. She is passionate about community-based research and enjoys collaborating with community members. Vanessa has worked under the supervision of Dr. Jacqueline Pye on several projects related to FASD, including self-regulation, employment, and housing. She is also currently involved in the ongoing research projects related to the Towards Healthy Outcomes model for individuals with FASD and client-oriented mapping for point-of-care access to supports and services, otherwise known as the COMPASS project. Vanessa's presentation is titled Creating Intersections, a systematic and person-centered harmonizing framework for housing individuals with FASD. Access to safe, affordable housing is a basic human right. Individuals with FASD have described challenges navigating housing supports due to programs not meeting the unique and ever-evolving needs of individuals with FASD. In this project, Vanessa and the research team brought together existing research findings with the lived experience of experts in the field of FASD and housing, including individuals with FASD, caregivers to individuals with FASD, housing support workers, and policymakers. This presentation will describe the collaborative processes that were used to help develop a framework to support individuals with FASD as they navigate housing services. So a very important and timely topic as well. And so with that, Vanessa, I will pass things over to you.
Awesome, thank you. And thanks everybody for coming today. I'm very excited to talk about this project. As Kelly mentioned, it is called Creating Intersections, a systematic and person-centered harmonizing framework for housing individuals with FASD. And before I get started with the presentation, I just want to do a land acknowledgement. As a student at the University of Alberta, I included the University of Alberta's land acknowledgement here, and a resident of Edmonton, Alberta. I just wanted to acknowledge that I live on Treaty 6 and acknowledge the sovereignty, lands, histories, languages, knowledge systems, and cultures of First Language, Métis, and Inuit nations who make up the collective community here. I'd also like to acknowledge the rest of the research team I worked with on this project, Elizabeth Carlson, Danielle Matson, Nicole Patrickney, and Dr. Cheryl Poth, as well as my supervisor, Dr. Jackie Pye, and all the other wonderful students who make up the Alberta Clinical and Community-Based Evaluation Research Team, as well as our funders, CanFASD and the U of A. So when we started this project, we really wanted to make sure that we situated it within why housing matters. And as Kelly mentioned in the description of this presentation, and as many of you have likely experienced, housing is an important basic human right. That is, as human beings, we all deserve the same level of respect and dignity, and part of that includes equal rights and access to housing. So everybody deserves to be housed, and on top of that, everybody deserves to have a house that is safe and secure. When people don't feel safe, it's really hard to focus on other things like getting to work, taking care of yourself, or maintaining relationships with other people. So housing meets a basic need that all humans deserve to have met. And finally, housing needs to be consistent to further support those feelings of safety, security, and dignity that people have within their homes and communities. And housing matters for many more reasons than these, but these are kind of the core ones that we found when we were discussing with people as part of this project and where we really situated our framework. So what did we do? Once we had set out about, a little bit about why housing matters, we started to explore what had already been done to support housing for people with FASD. So we started by looking at existing research through a literature review. And then after that, we decided to meet with some experts in fields related to housing and FASD. And we brought them together for a 2-day meeting to answer our questions and to learn from them in terms of what exists, what's working, and where there might be some gaps. Through those meetings and other meetings with community experts, we built a lot of connections. And through those connections, we eventually created a framework that I will explore a little bit more in depth in a moment. But to start, I just wanted to explain a little bit about what happened during the literature review. So this literature review, we started in 2017, and it basically just gave us a chance to look at what existing research was being done, give us an overview of what had been published, and give us an overview of what existed regarding housing and FASD in the research world. So our team used these search terms here. As you can see, we use search terms related to cognitive functioning, just a few different ways of putting that, as well as related to housing. And again, just a few different keywords related to that topic. And using these keywords in different combinations across 3 different databases, we got a total of 5,771 hits for these keywords. After reviewing those first results, we narrowed it down to 304 abstracts that we reviewed. And then from those abstracts, after reviewing those, removing duplicates or similar types of studies, we landed on reading 128 peer-reviewed articles that were published in English between 2007 and 2017, and that were peer-reviewed. Despite these big numbers, and we did find quite a few housing papers, projects related specifically to housing, there was not a lot of information about housing individuals specifically with FASD. So we still had a lot of questions about housing and FASD, so we decided to speak with some experts. And who were these experts that we met with? Well, we included government workers. They were there to share their insights regarding policy and to also hear from people within the community regarding how policy impacts them directly. We included housing workers because they were there to give us a boots on the ground insight, so to speak, on what is being done in terms of housing systems and programs. We wanted to understand what was already available and currently happening in terms of housing and related supports. From these experts, we learned a lot about a housing model called Housing First, which is a harm reduction approach to housing that provides individuals with access to safe, affordable housing right at the beginning of program and service delivery, so that other needs can be addressed later on once that sense of security and safety has been established. And how Housing First reinforces housing as a basic human right that addresses our needs for shelter, safety, and security. We also at the center here included people with FASD because we really wanted to center the lived experiences of individuals with FASD within our learning and collaboration, because people with FASD are the experts on what it is like living with FASD. And we wanted to learn from them so that we could include within our framework information about housing that was specifically from an FASD point of view. We also included caregivers to individuals with FASD, including parents and some support workers, so that we could hear from those who support individuals impacted by FASD directly. And from both the caregivers and individuals with FASD, we learned a lot about what was already being done, what successes they had experienced in terms of housing, and we also learned about what types of barriers there are to accessing housing supports. And finally, the researchers, so the University of Alberta group. We were there to learn from these experts and kind of share some of what we had learned about housing and kind of collaborate and form some of those connections. Through these conversations, not only was our team able to learn and make connections, but we also saw some ripple effects where these community members were also able to form connections with each other over the 2 days meetings. And through those connections, we were able to work alongside folks throughout the rest of our framework development so that we were really able to integrate housing and FASD in our framework. So What did we learn? Well, we learned a lot about the potential benefits and areas of challenge related to providing housing first for individuals with FASD. Lots of discussions were had around the importance of housing that meets basic needs, while also considering areas of strength and need so that the housing can be tailored to the person being supported. We also learned that it's important to think long-term when planning for housing. The supports a person needs when they're first moving into a new home, compared with later on once they've been in that house for a while, are likely to be very different. It's also important that we understand the person or the people with FASD that we work with. In particular, knowing that it's not only important to recognize their areas of need, but also what strengths can be leveraged to support those areas throughout the housing journey. We also learned that it is important to not only recognize when something is working, but not to change things if something seems to be working. As the saying goes, if it's not broke, don't fix it. If something is working to support someone's housing journey, we don't want to change that. And finally, we learned of the importance of ongoing communication with community members to continue to learn from their experiences and their expertise, because without those experts, this framework would have looked a lot different. So here is the title page of our framework. As I've said, it's called Creating Intersections, and it is meant to be a systematic and a person-centered framework that supports housing individuals with FASD. So at the center of the framework is this need for understanding the individual with FASD, their own unique set of strengths and areas of potential need. And we categorize these areas of need into 3 categories: basic, psychological, and self-fulfillment. And basically, we recognize throughout this framework that each individual enters into the housing process with unique areas of strength and need in all of these domains. So basic needs includes physiological and safety needs, such as access to housing, food, water, a sense of security and safety. Psychological needs include the experiences of relationship building, mental well-being, adaptive coping, and connection through culture, spirituality, and community. Self-fulfillment needs include the experience of a sense of belonging, finding purpose, and meaningful contribution to community, and being able to have a sense of giving back. So at the heart of the framework, as I said, are those 3 areas, and that is represented here by kind of a visual snapshot of the framework. And so this person-centered framework reflects a process of ongoing engagement between the individual being supported and the housing support workers or other supportive others in their lives. By focusing on the individual at the core of it, it makes it a lot it's helpful to setting realistic goals that apply over the long term for the person being supported. That is meant to be individualized in a way that also works alongside what is available within existing housing systems that in the community the individual lives in. So at the center of the framework is who, understanding the individual. Want to make sure that we have an understanding of their supports, any strengths and potential areas of need upon first contact, and how those things evolve and change over their housing journey. The individual's unique characteristics, strengths, needs, and existing systems of support are evaluated throughout in order to explore not only possible housing trajectories and the support services that may support the individual along the way, but also to identify the types of outcomes and goals they may want to strive towards. Then we also have the where, which directs kind of the pursuit of what is available within the community for housing, what would work for this individual in terms of housing programs, what is needed, what have they tried in the past and hasn't worked, and really just navigating that to kind of figure out what kind of housing placement is going to work for this type of person or for this person that we're supporting. We also have the how portion of the framework, which focuses on the long-term tenure and just fluid tailoring of supports, again, in relation to those unique characteristics and individualized goals of the person being supported. And this, again, requires that ongoing conversation and assessment of the individual's strengths, needs, and supports, so that as they progress through their housing programs and support services, we can ensure that the services are still meeting their unique and evolving needs. And finally, what happens? So this portion of the framework looks at evaluating the process outcomes. So understanding what goals were agreed upon by the individual and their housing support workers, and understanding that working towards those attainable goals, how is that happening, evaluating the outcomes of that, and making sure that we're still meeting those basic psychological and self-fulfillment needs. So, as I mentioned, oh, this looks a little blurry, but it is a, this is just a section, a small piece of a section within the framework that goes through some of that really tangible goal setting based on basic psychological and self-fulfillment needs. And so each of these tables, and they're a lot larger than what I'm showing here, provides examples of different types of, in this case, basic needs that the individual with FASD might want to have met through their housing journeys. So in this table here, this example, it provides is the individual with FASD would like connections to resources. And then they provide an example of how they will be able to access those resources. So here they say they will ask for help when they need it. Then the program staff says, well, what we can do to help with that goal is engage, connect with, and listen to the tenant, and gives different examples of that. And then how they're going to measure whether this outcome is being met is by keeping good notes. Does the individual have a housing connection? Talking to people, asking the individual about their housing connections and experiences, and working through that endpoint form in a collaborative sort of way provides an opportunity for the housing worker to not only get to know their client a little bit better, but to maintain that conversation over time and keep coming back to it and making sure that the housing program is supporting their needs. So same sort of thing here with the psychological needs. Again, it provides different examples and ways in which you can measure these outcomes. So the individual states that their goal is relationships. They will foster connection. How the housing program will support them is by providing relationally based services. And how they're going to identify that is by identifying which connections have been made and how relationships have been maintained. And then similarly, the self-fulfillment needs table. So I again would just like to stress that there are many more examples included in the housing framework, which can be found on the CanFASD website and provides a really great resource that individuals can take to their housing workers or other supportive others in their lives to help work with them when they're setting goals around housing and housing tenure. So in terms of next steps, I want to again say that we are still engaging in learning and communication with our community experts and with others in the community as well to make sure that we are not falling behind in any of those areas. We want to make sure as well that we particularly include individuals with FASD in these collaborative processes, because without them, these sorts of processes would look very different, and they provided really wonderful insight into developing this framework. And finally, it's also important that we continue to share our findings. We want to make sure that what we've been able to gather and share can be something that other people can access as well. So this is through peer-reviewed publications, as well as through community presentations like this one I'm doing right here, and other opportunities to just continue engaging in collaboration with community. So that is all for my presentation today. Thank you all very much. I've included my email here in case anybody wants to reach out with any questions. I'd also like to acknowledge that these slides were created by SlidesGo. And any questions? Yeah, thanks.
Thank you so much, Vanessa. Such a beautiful presentation, both visually and in terms of content. And I think an excellent note for us to end on. I would just like to say a big thank you and congratulations to all of our presenters today. This webinar does wrap up our trainee webinar series. And so as I mentioned on last week's webinar, it honestly has just been such a pleasure and a joy to get to know our 8 trainees as part of this pilot program, and really hoping this is going to continue to move us forward in terms of fostering collaboration and connection in the field. I'm so proud of each and every one of you. And I think the caliber of our trainees, their excellent presentations, both last week and this week, and the diversity of their areas really speaks to the strengths and the positives of the next generation of FASD researchers.